Does heart failure type impact the outcomes of Watchman Device? This analysis was performed from the National Readmission Database in the United States. Heart failure has been known to increase stroke risk in patients with atrial fibrillation. Anticoagulation remains effective in reducing stroke risk. Watchman Device placement may be the only option for atrial fibrillation patients who have increased risk for anticoagulation on a long-term basis. Our aim in this study was to compare the outcomes of heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction in atrial fibrillation after placement of the left atrial appendage closure device, which is known as Watchman Device. In our study, we identified patients from the National Readmission Database who underwent Watchman Device implantation between years of 2014 and 2018 using the billing codes ICD-9 and ICD-10. Patients were classified into two groups based on the type of heart failure, either reduced ejection fraction or preserved ejection fraction. Our results showed us that there was 3,840 patients have received the Watchman Device, out of which almost 2,100 patients had preserved ejection fraction, and 1,700 patients actually had reduced ejection fraction. The mean age between both groups were similar. However, the female sex was more frequent in patients with preserved ejection fraction. Obesity and prior permanent pacemaker placement were more frequent in the preserved ejection fraction group. However, the coronary artery disease and prior intracardiac defibrillator were more frequent among patients with reduced ejection fraction. There was no clinical significant difference noted between both groups in terms of index admission complications, as shown in Table 1. 8% of the patients were admitted within 30 days in the preserved ejection fraction, compared to 8% also in the reduced ejection fraction. The causes of readmissions for both groups included acute heart failure, which didn't have significant difference between two groups, as 29% versus 33% were readmitted. However, the GI bleeding was higher in the patients with preserved ejection fraction at a percentage of 27% versus 18%, and also intracranial bleeding was higher in the preserved ejection fraction group. There was no significant difference in the mortality or the length of stay between both groups. So, in summary, neither the frequency of the 30-day readmissions or the mortality was different between both groups. The GI bleeding represented a major cause of readmission in the heart failure with preserved ejection fraction group, and intracranial bleeding as well. So now additional studies are needed to identify the factors contributing to these events so that effective preventive measures could be instituted.